Hey guys, it's Rona again, PGY2 at Walter Reed, and today I just wanted to go over another shelf review slide with you. So this one is going to be more cardiac focused, but I'll still try to be more interdisciplinary and give you some time to think throughout the presentation. So starting off with mitral valve murmurs, which valvular condition is a risk factor for AFib? And I kind of gave it away with the title of the slide, but this one is going to be mitral stenosis. And the reason this question is interesting is it's actually testing your understanding of where the circuit for AFib is. So when they're actually doing an ablation, it's going to be right around these pulmonary veins here, and you can see it's right around this left atrium. So if you have mitral stenosis, which is causing additional stress from back up into the left atrium, that can be a risk factor for AFib. What is the murmur going to be for mitral stenosis? And the answer to this one is going to be a low-pitched diastolic murmur at the apex with an opening snap. And the key words that I think about here are it's diastolic, and it's one of the few diastolic murmurs, which we'll get into in a bit. It's at the apex, which is going to be all of those mitral valve murmurs, and it has an opening snap. And the way that I think about it is snap like an S for stenosis. So that's the way that I try to remember it. And then this is actually a really helpful mnemonic that Dr. Blythe taught me when I was a USIS student, and it's a mnemonic for all of the diastolic murmurs. So this one is arms pits, and she actually helped me learn that every time you see a diastolic murmur on a test, think about this mnemonic and which valvular condition is going to fit into that. Take a moment to think about what this might stand for. So AR is going to be aortic regurgitation. MS is going to be mitral stenosis. PI is going to be pulmonic insufficiency or regurgitation, and then TS is going to be tricuspid stenosis. So every time you see a description of a diastolic murmur on your exam, just think about this mnemonic and which of the valvular conditions they might be referring to. So going back, we see that this is a diastolic murmur for mitral stenosis. For that MS of that mnemonic, it's at the apex, which is that mitral area, and just remember SNAP for stenosis. And what is the murmur for mitral regurgitation? So again, it's going to be at the apex. We mentioned that all of the mitral valve murmurs are going to be in that area. This one is going to be holosystolic, and it's going to radiate to the axilla. And what about here? What about a patient who is coming in with decompensated heart failure and an apical holosystolic murmur, which actually disappears after diuretics? So remember that apical holosystolic murmur is referring to mitral regurgitation, and this is actually referring to secondary mitral regurgitation and the second volume overload of the heart failure exacerbation. And what they're trying to get you at is that the first thing you should be doing is treating the heart failure in this setting. And which infection history are you thinking about with primary MS? The answer to this one is going to be rheumatic fever. And what is the murmur for mitral valve prolapse? So again, remembering that the mitral valve murmurs are all going to be at the apex, and this is not part of that mnemonic, so it's going to be a systolic murmur. You have a click and a high frequency murmur, and the way that you might see it on a test exam is a high frequency mid to late systolic murmur that is best heard at the apex. And the way that I remember this is prolapse here has a curve in the letter P, kind of like how the click has a curve like C. And remember, you have click for prolapse and then a snap for stenosis. And what is the number one cause of mitral valve prolapse in developed countries? And this one is going to be myxomatous degeneration. And then what is this EKG suggesting? So this one is going to be an inferior MI. And you can see here you have ST elevations in 2, 3 AVF, as well as reciprocal ST depressions here. And this is on the topic of mitral valve murmurs. So think about for a moment what I might be referring to and why this EKG might be on the screen. And just remembering that inferior MI, when you say that you have these ST elevations in 2-3 AVF, the most common cause is going to be an RCA occlusion. Less frequently, it can be the left circ. And what if that patient who had that inferior MI came in with a new systolic murmur? So think about acute mitral regurgitation in this setting, and that was kind of why I was showing an inferior STEMI in the setting of our mitral valve topic. And the reason for this is that you have this mitral papillary muscle, which has a singular blood supply. So you can have acute mitral regurgitation if you have a blockage, which is going to cause abrupt blood backflow from the LV to the LA during systole. And what is going to be the time frame for this post-MI complication? The answer to that is going to be acutely within 5 days. And what other clinical findings would you expect with acute MR as a post-MI complication? So these patients are going to be very, very sick. If you think about it, the blood is going backwards, so it's not going forwards the way it should be. So these patients are going to present with cardiogenic shock, poor output in the setting of that blood not being able to move forwards, as well as congestion with things like pulmonary edema. And what about a 24-year-old female thinking about pregnancy? You hear a low-pitched diastolic murmur with an opening snap at the apex on physical exam. Which valvular condition does she have? So again, remembering our buzzwords here, the apex is going to be the mitral area, and then the opening snap is a clue for our mitral stenosis. So she has mitral stenosis. And how do you counsel this patient when she's thinking about pregnancy? The answer to this on the boards is that it's going to be a contraindication to pregnancy, and you generally need treatment with surgery before. And the reason for this, if you think about it, is that pregnancy is going to be a more high outflow state. So when you have a closed off mitral valve where the blood can't move through well, that could be a severe risk to both mom and baby. And which other valvular condition, when you just think about that, would also be a contraindication to pregnancy? And this one is not as common, but it's going to be aortic stenosis. So this is just a summary of all of our mitral valve buzzwords here. Feel free to take a picture of this one slide. So mitral stenosis, thinking about that snap, a risk factor for AFib. It's going to be one of our diastolic murmurs. Just remembering again what that mnemonic for the diastolic murmurs is. Pregnancy is contraindicated with mitral stenosis. And think about it if you have a history of acute rheumatic fever. Mitral regurgitation is going to be holosystolic, that radiates to the axilla. And think about it if someone had that history of an acute MI and are now showing up with some acute valvular issue. And then mitral valve prolapse is going to be our mid-systolic click. High frequency murmur and myxomatous degeneration is going to be a big cause of this. And now moving on to a different cardiac issue. So hypertrophic obstructive cardiomyopathy, what is going to be the murmur with this condition? So the answer to this one is going to be a crescendo decrescendo systolic murmur. And remember that this is going to be an obstruction of blood going from the left ventricle to the rest of the body. And so which valvular condition would sound similar? And I just mentioned that this is going to be a condition where blood is having trouble moving from the left ventricle to the aorta. So aortic stenosis is actually going to be a pretty similar sounding murmur. And this is how the test might get you, is that they're both going to be crescendo decrescendo systolic murmurs. And this picture here is just visualizing what we're actually looking at when you have hypertrophic obstructive cardiomyopathy. And you can see it actually looks kind of similar in a way to aortic stenosis, where the blood in that left ventricle is having to move through a smaller opening to move to the aorta. Now, there is something that differentiates HOCM from aortic stenosis, and you can think about this in terms of what would increase the murmur. So what will increase the HOCM murmur? So if you decrease preload, essentially what you're doing is you're making it more floppy is how I visualize it. So it's more floppy, it's not able to be propped up, and the blood has trouble leaving that left ventricle. So anything that makes it more floppy because there's less blood, which is going to be decreasing preload, is going to increase the murmur. Things like Valsalva, standing abruptly, or nitroglycerin, which will cause peripheral vasodilation, so the blood is all pooling in your extremities. And again, thinking about the mechanism for this, if you think about it, if you have more blood that's kind of propping up this area, that'll be better for HOCM, while if you have less blood or less preload, it'll make the murmur go louder. And how do you treat HOCM? And the answer for this is going to be a beta blocker, and the way that I think about it is if you slow down the heart, give it more time to fill, that's going to help, again, that obstruction. And what if you can't use a beta blocker? The answer for this is going to be verapamil or diltiazem. And then just a summary of everything for HOCM, the symptomatic treatment is going to be beta blocker or verapamil and diltiazem. You'll see some EKG abnormalities with this one, so you could see left axis deviation, also issues with both depolarization and repolarization, so prominent Q waves, T wave inversions. And then this is going to be the one that's a crescendo decrescendo systolic murmur that increases with things that decrease preload, like Valsalva, standing, and nitroglycerin, and then decreases with things that increase preload, so things like a sustained hand grip, squatting, or passive leg raise. And which genetic condition is associated with HOCM? The answer for this one is going to be Friedreich ataxia, and the number one cause of death is actually heart failure secondary to HOCM on UWorld. And which are the two murmurs which do not get louder with increased preload? So this one is going to be HOCM and mitral valve prolapse. And the way I think about this one is I visualize something that's floppy in both conditions. So when you have more blood to kind of prop things up, that's going to make things better. And this is differentiating hokum from athlete's heart. So, one thing is the family history. I think this is going to be something they don't give as frequently because it'll make it a little more obvious. But if you do have family history of a family member who passed suddenly from an unexplained reason, who maybe drowned while swimming, think of hokum more on your radar. If you have EKG abnormalities, that's going to be hokum and not athlete's heart on your exam if there are things like Q waves and T wave inversions. But if you just have left ventricular hypertrophy without anything else, it could be either. The size of the left atrium is going to be large in hokum, but it's going to be normal in athlete's heart. And then the LV size is going to be smaller in hokum and slightly enlarged in athlete's heart. And then the LV wall thickness, it could be thicker in athlete's heart, but it should be less than 15 millimeters. If it's 15 millimeters or more, think about hokum. And then the diastolic function for the left ventricle is going to be normal for athlete's heart, but impaired for hokum. And then finally, I'm just going to compare hokum to aortic stenosis. And both of these are going to have a crescendo decrescendo murmur. I really want you to visualize this picture whenever you think of a hokum question and understand why it would be similar to aortic stenosis with the sound of that murmur. Both of those are going to be something where you have difficulty with the blood going from the left ventricle to the aorta. But in hokum, there are some differences. There should be no ejection click, while for AS you might have an ejection click. The carotid pulses might be softer and delayed in AS, but they should be brisk and rapid for hokum. On your exam, aortic stenosis is going to be rare in patients who are less than 40 years of age, and hokum is going to be more common with our younger adults and adolescents. And hokum is going to be loudest at the left upper sternal border, while AS is loudest at the right upper sternal border. And then just remembering again, it really helps me when I visualize hokum as something where you have something floppy, where if you have more blood, it helps prop things up. So that helps you visualize why for hokum, if you have more preload or more blood, that would actually help the situation and make the murmur be more quiet. While for aortic stenosis, I think about it as trying to push things through a very small door. So if you have more preload or more blood that you're trying to push through a very fixed small door, that murmur is going to get louder and the situation is going to get worse. So think about that when you're trying to differentiate whether the murmur is getting louder or quieter with increased preload. Right, so that's all I had. I hope this was helpful. I'd love to hear your feedback again, and if anyone wants to reach out to me at any time, please feel free.